Um, so this is my friend Anna. Anna is an activista which is a fancy term which I'll teach you about in a second, in southern Mozambique. She was chosen by her church to visit families in her community who are affected by HIV. And when I met her last year, the project had finished, but she was still visiting 3 to 4 families a couple of times every week to provide home-based care for people living with HIV, making sure that they're taking their medication, to meet with families that have orphans and vulnerable children in their house, and just to serve them. So today, as I talk to you about this project, we'll talk about how the local church is a vital but often untapped resource in communities for increasing treatment and prevention of HIV among vulnerable populations. So Anna was part of the community care program, or the Programa de Cuidados Comunitários. I don't speak Portuguese, but I think that's how you say it. In Inhambane province in Mozambique, which you'll see right there. The project went from 2011 to 2015. It's funded by USAID, and World Relief was a subgrantee under FHI 360. So the program was designed to strengthen the community-based response to HIV in 7 provinces, and to improve the health and quality of life for people living with HIV, OVCs, and pre- and postpartum women. So World Relief just had 1 of the 7 provinces. We worked in 5 districts in Inhambane, and provided physical, informational, and psychosocial support and referrals for people living with HIV in these vulnerable populations to treat and prevent the spread of HIV. So the expected results of the project overall were increased provision of comprehensive community-based care and support services for people living with HIV and their families, increased family-centered, community-based services that improve health outcomes and quality of life for people living with HIV, OVCs, and pre- and postpartum women that are implemented by the coordinated efforts of the Ministry of Health, the Ministry of Gender, Children, and Social Action, and community-based organizations. And the third expected result was the increased number of HIV/AIDS positive individuals and affected households that have adequate assets to absorb the shocks brought on by chronic illness. So there were 6 kind of cross-cutting strategies that they used to ensure sustainability. So there were community mobilization, community-driven approaches, services integration and networking, capacity building, partnership coordination and linkages, and gender-sensitive and age-appropriate interventions. So a lot of terms you've probably heard a lot thrown around everywhere. So World Relief focused on, this was a kind of a different project for us because we were really focused on building capacity of these specific organizations instead of directly implementing. So in these 5 districts that we worked in, we worked with 3 pastors' networks and 2 community-based organizations that were led by people living with HIV. So today I'm going to talk about the pastors' networks that we worked with. So we had these 3 networks. They actually, World Relief helped to form these organizations in a prior USAID-funded project. And so they were the Rede Pastoral de Inharime and Morumbene and Homoini. Those are the 3. So each network had 25 churches or pastors that were involved. They were organized into networks to reach their entire district, not just their communities, but their entire area. They were organized and equipped to become independent civil society organizations that mobilized and trained community health workers called activistas, like Anna, who I showed you before. So activistas were chosen from congregations to provide home-based care and referrals for people living with HIV, support for orphans and vulnerable children, support for prevention of mother-to-child transmission of HIV, community nutrition counseling, and tracking and counseling of people living with HIV who had abandoned treatment. So going and finding them and bringing them back. So in these networks, the pastors, I use the term contribution as commitment. So each of the churches, different networks kind of came up with different rules, but in one I really appreciated, each of the churches represented was required to contribute some land to the network as kind of part of their buy-in to the project. And they all contributed, each an activista, each church chose one person to do that work. And then they also contributed for staff and administration and just their manpower and hours. And capacity, as I said, capacity building was a really big part of this project. So World Relief was working and sending our supervisors to these projects, to these offices and out to the field, and training them in how to train their activistas in the things they needed to know, but also in financial management and in monitoring and evaluation and all these different things that would be important for them to be independent as an organization. So reach and impact. So throughout the project, the project World Relief reached over 13,000. I think that even might be a very lowball number. People living with HIV, OVCs, and pre- and postpartum women. And activistas were integrated into the local health system. When the project closed, they came under the wing of the Ministry of Health. The Ministry of Health requires that they be paid, and so last I've heard, some have been paid and some haven't, but that responsibility is being taken over by the government. One really powerful thing, I think, was that churches before, many that we spoke to, did not talk about HIV. I like to think that we've come far enough that people can talk about it, but there still is that problem and that trouble. And so these churches were saying, now we can talk about HIV. We have pastors who are talking about giving advice to their parishioners about HIV. The activistas are regularly given time to stand up in front of their congregation and talk about the work that they're doing, the families they're visiting, to talk about the issues that maybe still need to be addressed that haven't been that the project maybe can't address, but maybe the church can come in and fill some of those problems. We saw an increase in adherence to treatment because of this regular visiting that people were getting, and school attendance by OVCs. So part of the package that orphans and vulnerable children received was helping make sure that they were registered for school, understanding the things that they could get from the government for birth registration and for school fees and all these things that could be covered. And then at the end of the 3 pastors networks, 2 of them had secured outside grants and funding, and were able to manage those at the end, which was really exciting to see them in their ability to be independent. This is one of our activistas with one of her home-based care clients. So keys to success. So they're actually called super activistas, which I love this term because I imagine them with capes behind them, which maybe wouldn't be culturally appropriate. Mona's laughing at me in the back. But so these activistas were different because they weren't just trained in home-based care. Typically, you'd have a home-based care person and maybe someone who works with orphans and someone who comes and does this or that. But these activistas were trained in all of these things. They were very comprehensive. But because of that, they could come into a household and be the main point person for all of these things. So they really built this sense of trust with families where they could come and help with all the different areas that they had trouble with, teaching them about nutrition even, and other areas. And because of that, because they were reaching the whole family, the community really saw a decreased stigma towards HIV because they didn't know, oh, they're just coming to visit that person who has HIV. They said, oh, they're coming to visit the family. And so that was a really big part of that. As I was mentioning before, the counseling that came from the church, as the churches learned how to do that, was really exciting. And neighbors and community leaders were really essential in helping to find those who needed support or those who were lost to treatment. So as we worked with the health centers and the health system, they would give us a list of people who had been lost to treatment. And so our activistas would have to go and find them in the community. And who better to talk to than the local leaders and the neighbors who could say, oh, I think that person maybe moved there, or they're this place or that place. And another key was just recognizing that we needed to invest a higher level of effort working with these pastors' networks to increase their capacity. These networks were coming from a lower level of capacity than our other CSOs that we were working with. So we really needed to spend the time to increase their technical, financial, and reporting capacities. So we all have challenges, and this project was no different. One big problem one challenge was monitoring and evaluation. I think we all see that in so many of our projects, that it can be hard to keep track of things. And we were working, the activistas were working closely with providing referrals to health centers and then getting counter referrals back, which would be these forms that you see over on the side. And changing of forms and other things could be a challenge, but then also just getting buy-in from the health centers and from the Ministry of Health to actually, or not the Ministry of Health, more at the community level in the health centers, to get those filled out and back and forth, and all those logistics could be challenging. So as I was saying, just really the level of effort required for building capacity of pastors' networks could be a challenge, but we turned it into a lesson learned and just something that we understand that we need to do. Reaching pre- and postpartum women and reaching men were both challenges because of beliefs, that kind of underlying beliefs and issues. Some of the women that we worked with said, "Oh, I don't need to get tested for HIV. HIV is related to, those people are weak," or "I'm not weak," or "I don't," even if they did get tested, they would reject the result that they got because they didn't want to have HIV. And likewise with men, we did some messaging on parenting skills, and just because of beliefs about the roles of men and women and other things, men didn't really want to be involved. And so how can we engage with men and talk about being a good parent? So those are things we had to address. And another challenge, which we often face in a lot of our different places, is political instability. Which, just throw that one little piece out there. It's a very complex issue. So some lessons learned. We have to reach whole families. Taking this family-centered, family-strengthening approach is really important. And throughout all of the reports that I read, it kept coming back to people saying, when you came and served my whole family, that meant that I trusted you and I could come to you with my challenges. And so I think reaching whole families is central to achieving these improved outcomes. These activistas, they were also trained in gender-based violence. And so over time, and just kind of recognizing signs and doing referrals. So over time, because they were spending time with these families, they could refer women to local government and to get justice for cases of gender-based violence in the home. And those are things that you have to have so much trust with that person in order to even be able to speak about that. So that's really, I think, just indicative of what they were seeing. The second one is that knowledge isn't enough. beliefs impact our behavior. And so we talked about some of the beliefs that we talked about before. But we have to be mindful of this in our design. And it will continue to be a challenge if we don't continue to work at it. So I think Victoria, other people have been talking about this throughout this, that we can't just address knowledge, but we have to impact these beliefs and see how they impact behaviors. The contribution of churches has a resulting commitment to the work. Working with health systems, it takes time and it takes trust. It doesn't work overnight, and we have to be vigilant in reporting and in relationships, both at the high level and at the low level, getting that buy-in for the work that we're doing. And the role of local leaders and church leaders is key in identifying cases, filling in gaps in services, and increasing male involvement. So, the end of the project, I loved just hearing some of these quotes that participants had. And they said it was like a wedding where nurses rely on activistas and vice versa, with confidence and respect between them. Speaking of the strengthening we have of the health system, I said before there was no space to talk about HIV in the church, and at the end there was. Of activistas, they're now recognized as trainers in the community. And the church can help to increase self-esteem and can work with people who do and do not come from the church, so serving the whole community. And all people in the church are moved by faith, moved to charity. We're not afraid when there are not funds, because all of our people do their work by faith. They believe in what they're doing so that they can still carry on. And so I think that speaks to why the church is so important. At World Relief, our mission statement is to empower the local church to serve the most vulnerable, because we know that even if we leave, the church stays. And so how can we do this? And we're seeing in these networks how the church really has a powerful impact. So at the end, the networks were strengthened to the point where many were able to still operate and continue on with the work. And while they're effective in addressing HIV in communities, they exhibit promise as a model for grassroots community mobilization to address a wide variety of health issues. So imagine another person like Anna in the community that you work in. It's through people who, like her, who are committed to reaching their communities, that we can see long-lasting change, not just in the lives of people living with HIV, but in all areas of family health, from nutrition to child development to gender-based violence and all these things in between. So, thank you very much.
Cheers.